Good morning, dear students. Last time, so last class I think I was telling you about the oral cavity and its boundaries, how it starts in the anteriorly to the lips and ends at the junction between the base of the tongue, anterior to the tongue, base of the tongue, and the palatal-glossus muscle, how it demarcates the oral cavity from the oropharynx. Now, we will go in short detail about the anatomy of the pharynx. Anatomy of the pharynx. Now, pharynx is conical. You know what a cone is, broad base and then narrows down. And it's a structure which is extending from the base of skull, basi-occiput and basi-sphenoid. Okay? That is the basi-occiput and that's the basi-sphenoid, that's bone. It starts from there and right up to the cricopharyngeal sphincter. So this is a tube, conical, as I said, extending from the basi-occiput, basi-sphenoid to the cricopharyngeal sphincter. Okay? This is divided into three parts, and these are: one is the nasopharynx, the part which is behind the nasal cavity, that is behind the choana forms the anterior end. And posteriorly, of course, you have the prevertebral muscles, and behind that you have the vertebral bodies. Then you have as it comes down, roughly at the level of the soft palate, imaginary line drawn at the level of the soft palate. From there to an imaginary line drawn at the level of the epiglottis, tip of the epiglottis. That cavity is called the oropharynx. And posteriorly you have the vertebral bodies second and third. Okay. Anteriorly it opens into the oral cavity. And third one is the laryngopharynx, which starts at this imaginary line drawn at the level of the epiglottis to the cricopharyngeal sphincter. That is the laryngopharynx, into which the larynx opens anteriorly. Okay? So the pharynx is a muscular tube which is extending from the base skull to the cricopharynx, divided into three parts: nasopharynx, oropharynx, and the nasopharynx. Nasopharynx is behind the nose. Oropharynx is behind the oral cavity, and the hypopharynx is behind the opening of the larynx. Now we will try to slowly understand how this how is structurally made. Now, as I said, it's a tube, a conical tube, which is opened anteriorly. Anteriorly, you have the nasal cavity, oral cavity, and the larynx. Laterally and posteriorly, it is a muscular tube. And if you see from inside, this is on the right side, if you see the section, initially you have the mucous membrane. The mucous membrane in the nasopharynx is the respiratory epithelium, cirrhosis columnar epithelium, which slowly gets transformed, or there is a transition when it comes to the oropharynx. The mucous membrane is stratified squamous epithelium, which further continues into the laryngopharynx as stratified squamous epithelium itself. Okay, so that is the inner lining, and beyond that you have the pharyngeal aponeurosis. Lateral to that you have the muscle, and these muscles which cover the tube laterally and posteriorly. There are three muscles which are called the constrictor muscles, and these are the constrictor muscles which are or on the lateral side and posterior aspect. And there are some longitudinal muscles which are a little deep to this. The longitudinal muscles, I'll show you. The longitudinal muscles are the stylopharyngeus, which is extending from the styloid process, the palatopharyngeus to the palate to the pharynx, and salpingopharyngeus. These are the three muscles that you see here. Okay? And of course the constrictor muscles, which form like a tube. Now if you see, this is a view which is from behind, and this is the base skull, and there is a tubercle, a pharyngeal tubercle, from where there is a midline fibrous band that is attached, and these superior constrictor muscle, the middle constrictor and inferior constrictor muscles, which are something like three parts put one in another. Okay, so the superior constrictor is the one initially, and you have these middle constrictor and inferior constrictor muscles. So this is the pharyngeal tube that is formed, and as I said, the mucous membrane in the nasopharynx is the pseudostratified ciliated columnar epithelium, and slowly as it comes down, it becomes the squamous epithelium in the oropharynx. Okay? Then you have the pharyngeal aponeurosis, which is otherwise called the pharyngobasilar fascia. The second layer that is seen in the green, the pharyngobasilar fascia. And then you have the muscles, the constrictor muscles, and the muscles, longitudinal muscles that I mentioned. And deeper to that, you have the buccopharyngeal fascia. The buccopharyngeal fascia, which is lying laterally, and lateral to this, you have spaces. There are two spaces which are in relation to the pharynx. These spaces are, one is a parapharyngeal space, the other one is the retropharyngeal space. Two spaces in relation to the pharynx. So basically it's a tube which is lined by these layers, and lateral to that is the parapharyngeal space, and behind is the retropharyngeal space. So, and if you go into the individual areas, that is start with the nasopharynx, or let's see how the constrictor muscles, this is the base of skull, and superior constrictor is here, and that's the middle constrictor muscle. Okay. And superior constrictor is a broad muscle which is in relation to the nasopharynx as well as the oropharynx. Okay. And the middle constrictor muscle is the next muscle, and the inferior constrictor muscle. Now, if you see the superior constrictor muscle, the attachments will not go into the details, because basically you should remember that is the one which is lateral to the nasopharynx as well as the oropharynx. And there is a space in between the base of skull and the superior border of the superior constrictor muscle. This space is the one through which some of the palatine muscles come into the palate, and also the eustachian tube, which is connecting between the nasopharynx and the medial cavity. that is about the superior constrictor, and this is the middle constrictor muscle as I have shown here from the lateral view. And then you have the inferior constrictor muscle, where there are two components. One is thyropharyngeus, which is coming from the thyroid cartilage, to the midline raphe, as I told you. All these muscles are inside there. And the cricopharyngeus muscle. So, thyropharyngeus and cricopharyngeus muscle. In between there is a small area between these two, which is a weak area sometimes, where there can be herniation of the mucous membrane of the pharynx, which is called Achilles diverticulum. So that is in brief about the constrictor muscles, and let us see. This is the constrictor muscle, inferior constrictor muscle, which forms the thyropharyngeus and the cricopharyngeus, which is the cricopharyngeal sphincter, where the hypopharynx ends and the esophagus starts. Now, as I told you, all these muscles are attached to a midline raphe, the fibrous band. And I told you there are two spaces which are retropharyngeal space, situated behind the pharynx, and the parapharyngeal space situated on the side of the pharynx. Just remember those. And the pharyngeal plexus, the nerves which supply the sensory as well as the motor, are derived from the pharyngeal plexus, and these are formed by the glossopharyngeal and the vagus nerves. Okay, that the pharyngeal branch of the vagus supplies all the muscles of the pharynx, excluding the stylopharyngeus muscle, which is supplied by glossopharynx. So the nerve supply is from the 9th and the 10th via the pharyngeal plexus. Then we go into a little detail about the nasopharynx. The nasopharynx, anteriorly it opens into the nasal cavity. That is the posterior limit of the nasal cavity is the choana. And then superiorly, as I said, the basisphenoid and the basiocciput. And posteriorly, the fascia and the muscles in front of the vertebral bodies. And inferiorly, anteriorly the surface of the soft palate, and an imaginary line drawn at the level of the soft palate. That is the nasopharynx. So anterior and the posterior, lateral, there are some important structures we will study. So anteriorly the choana, posteriorly vertebral bodies, and inferiorly an imaginary line drawn at the level of the soft palate, and superiorly basisphenoid and basiocciput. Get familiar with these names. So that is a cavity, and laterally, as I said, it is the same constrictor muscles, the superior constrictor muscle that is there laterally, but there is a small space between the base skull and the superior border of the constrictor muscle, which is called the sinus of Morgagni, through which let me show you that. Through which the sinus of Morgagni, it's a space where the muscle is absent, and so that it formed, that is structure through which the eustachian tube passes. Then, that is as far as the nasopharynx. Then we go into the lateral wall of the nasal cavity, nasopharynx. The nasopharynx, this is another diagrammatic representation of the pharynx, how it is divided into nasopharynx, oropharynx, and hypopharynx. So these are the things which you should remember. And now, the nasopharynx, the anterior the lateral wall. So we said the superior wall, the inferior wall, and the anterior and the posterior walls we have discussed. Only the lateral wall of the nasopharynx consists of eustachian tubal orifice just behind the inferior terminate, 1.25 centimeters from the inferior terminate posteriorly. There is an opening called opening for the eustachian tube, and this eustachian tubal opening is bound above and behind by a cartilage which is called torus tubaris. Cartilage called torus tubaris, and above and behind the tubal elevation is a recess called above and is called fossa of Rosenmuller, okay, where the common site, which is a common site for the origin of the carcinoma. And the third one is the salpingopharyngeal fold, a ridge extending from the lower end of the torus tubaris to the lateral pharyngeal wall raised by salpingopharyngeal muscle. So that is about the lateral wall of the nasopharynx, the eustachian tubal opening, the torus tubaris, the fossa of Rosenmuller. In addition to that, you have in the roof of the nasopharynx, the adenoid mass, the mucosa is thrown into folds, wherein there is a underlying lymphoid tissue, which is the nasopharyngeal tonsil, otherwise called adenoids, which is situated in the roof and the posterior junction of the posterior wall of the nasopharynx. So this is called the nasopharyngeal tonsil, otherwise the adenoids, which is common. Now these are nothing but subepithelial collection of lymphoid tissue at the junction of the roof and posterior wall of the nasopharynx, and causes the overlying mucosa membrane thrown into radiating folds, various folds. This increases in size up to the age of 6 years and then gradually comes down. Its size comes down. Now, associated along with this, there are two components. One is the nasopharyngeal bursa. Nasopharyngeal bursa, which is something embryologically related to the notochord, and there is a Rathke's pouch, which is anteriorly situated, which is embryologically the mucosal fold, which is in relation to the sphenoid. Okay? So these are the structures that are present in the nasopharynx. And apart from that, you have the regular adenoids. These adenoids at once, which are subepithelial collection of lymphoid tissue. In the nasopharynx, they are called the adenoids or nasopharyngeal tonsil. This is something which you have to remember. Is important for the ENT purview. Now, the nasopharyngeal bursa, as I told you, is this is the nasopharyngeal bursa, and which is in relation to the attachment of the notochord in the pharyngeal endoderm. And if this bursa gets infected, it becomes bursitis and abscess formation, and this is called Thornwald's disease. Thornwald's disease. This is embedded in the adenoid mass itself. The other one is the Rathke's pouch, which is in relation embryologically to the pituitary, which is situated anteriorly. You don't have to just remember these things. Okay, those are the structures which are present in the nasopharynx, and the tubal tonsils. Then, after coming from the roof of the nasopharynx, the tubal tonsils. These are collections of epithelial lymphoid tissue which are in relation to the eustachian tube opening. This is the eustachian tube opening, and this is the torus tubaris. Okay, and these are situated in the posterior in relation to the eustachian tubal orifice. This is called the the tubal tonsil. And then, as I told you, the sinus of Morgagni, through which the eustachian tube is passing between the nasopharynx to the middle ear cavity. And the other structures which are passing through are levator villi palatini, tensa villi palatini, and ascending palatine artery. Just read them and forget about them. The fossa of Rosenmuller, which is a common area where nasopharyngeal carcinomas occur and how they spread into the brain, the soft palate, the auditory tube, and the nasal cavity. Now, from the nasopharynx, the roof, go to the floor of the nasopharynx, that is the velopharyngeal space or isthmus. There is a mucosal ridge raised by fibers of the palatopharyngeus. There is a muscle coming from the palate to the pharynx, palatopharyngeus muscle, and when this muscle contracts, it forms a small ridge in the posterior wall of the pharynx, posteriorly and also laterally. And that is the one ridge. When the soft palate moves upwards in the deglutition phase, it seals the nasopharynx from the oropharynx, so that the food or the liquids when you swallow, they do not go into the nasopharynx. This is called the ridge is called the passerence ridge, and the that valve is called velopharyngeal isthmus. So that is the demarcation between the oropharynx and the nasopharynx, and the soft palate meets that ridge, and then the food is prevented from going into the nasopharynx during deglutition. That is the important aspect of this. Then, of course, the lymphatic drainage, they are drained into deep cervical nodes, retropharyngeal nodes, and parapharyngeal nodes, and this finally through the spinal axillary chain of nodes into the posterior triangle of the neck. That is the importance of the nasopharyngeal lymphatic drainage, because nasopharyngeal carcinomas usually present as lymph nodes, metastatic lymph nodes in the posterior triangle of the neck. Now, the functions of these are easily understood. It ventilates the middle ear cavity through the eustachian tube. It cuts off nasopharynx from the oropharynx with the help of passerence ridge. It acts as a resonating chamber for voice production, acts as a drainage channel for the mucus secreted by the nasal cavity, and how it nasociliary movement, where the mucus is driven into the posterior nasopharynx and then goes down into the pharynx, laryngopharynx, and then ultimately swallowed. That is the mucociliary clearance. And then the oral cavity or the pharynx is richly surrounded by the lymphoid aggregations, lymphoid collections, because this is the route of entry for any of these infections to travel, either through air, food, or water-borne infections. They have to go through this, either through the nasal cavity or through the oral cavity. And so this area is widely networked with the lymphoid collections, because these are the ones which are said to be responsible for the immunological process that takes place in the body, and they form a system called reticuloendothelial system. Now, these are the Walde's ring is there is an inner ring which you see as the violet one, and the other lymph nodes, the outer ring. Now let us concentrate on the inner ring. Now, the nasopharyngeal tonsil or the adenoids is in the roof of the nasopharynx, that is the one, Then you have the tubal tonsil, which is on the lateral aspect of the nasopharynx. Then you have the palatine tonsil and you have the lingual tonsil. These form a ring, which is called the inner ring. The adenoids, nasopharyngeal tonsil, the tubal tonsils, the palatine tonsils, which we usually refer as the tonsil, and this is the lingual tonsil. These are the ones which form the inner ring. Whereas the outer ring is formed by retropharyngeal nodes, that is behind the pharynx, retropharyngeal nodes, or sometimes the suboccipital nodes also. Then you have the jugulodigastric nodes. Then you have the submandibular group of nodes and the submental. So these are the ones which form the outer ring. So this is an important Walde's ring, and the inner ring and the outer ring, how they are constituted. So this is important for you to remember. Then adenoids, which are called the nasopharyngeal tonsils, which are situated behind the mass of lymphoid tissue, and usually undergoes atrophy at the time of puberty. The adenoids, how they look: a pink globular mass, but vertical ridges on its surface. There are no crypts, lined by ciliated columnar epithelium, and there is no capsule. This is the structure of the adenoids. And if you see the anatomy, the blood supply, ascending palatine branch of the facial artery, and the ascending pharyngeal artery, and pharyngeal branch of the third part of the maxillary artery. These are the blood supply to the adenoids. And lymphatic drainage is upper deep cervical lymph nodes, retropharyngeal nodes, and the parapharyngeal nodes. Now, when you take an X-ray radiologically, this is the nasal cavity, this is the upper teeth, lower teeth, and this is the mandible, and this is the nasal cavity, and behind that is the nasopharynx, where you see there is a soft tissue mass. That is the radiological evidence that the adenoids, they narrow the air passage. Now, usually they get hypertrophied because of this irritant focus, and the causes of you can easily predict, because they produce nasal obstruction and snoring, the mouth breathing because nose is blocked. Rhinolalia clausa is a situation where the nasopharynx reverberation is cut off, and so the air that is coming through the oropharynx coming into the nasopharynx is blocked because of the enlargement of the adenoids, and so they produce a peculiar voice which is called rhinolalia clausa. And of course the frequent infection, rhinorrhea, sometimes bleeding, and because during deglutition usually the nasal breathing occurs, and so because the nose is blocked, it is difficult to swallow. The conductive deafness because of the eustachian tube block and secretory otitis media, and the lymphoid enlargement, lymph nodal enlargement, and the most important factor which says that the adenoids are enlarged, they produce a thing called an entity called the adenoid facies, and they are the ones who are prone to repeated respiratory infections because they keep breathing through the mouth, wherein the filtration and the temperature regulation and the temperature regulation are totally absent, and so the direct air from the atmosphere is inhaled into the lower respiratory tract, and so they are prone for repeated chest infections. and of course the general anorexia and lethargy. Now this is how the adenoid face is. Boy looks dull, and the absence of the nasolabial folds and long drawn face. Mouth is open, and if you look inside you have the crowded teeth, and because the open mouth there is drooling of the saliva, and of course anteriorly they may have from the nose the rhinorrhea, and these are the features which are called the adenoid faces. This is sometimes asked as a short nose. So this you should remember. And the oral manifestations, because of the eustachian tubal orifice, the infection spreading from the nasopharynx into the middle cavity, the secretory otitis media, acute otitis media, and the chronic otitis media. These are the ones which are as a result of a septic focus present in the nasopharynx in the form of adenoiditis. Then the diagnosis is nasal obstruction, simple, and radiologically we have seen the X-ray, and the differential diagnosis, as I told you, the thorn wall cyst. These are the complications if the adenoids are there in the nasopharynx, which obstruct the nasal airway passage. Then the treatment is usually, if there the obstruction, you can manage them initially. Medical management, antibiotics, anti-inflammatory analgesics, nasal decongestants may establish a little passage and for the air to go. And so as the age advances, slowly there is a hypertrophy of the, or diminished size in size of the adenoid mass, and so you can manage sometimes with this medical conservative management. But if they don't respond to medical management, the surgical treatment is the adenoidectomy and the myringotomy with bromide, because there is because of the obstruction of the eustachian tube, there is fluid in the medial cavity. So, and the procedure, we will not go into the details of the procedure, is simple. There is an adenoid curette, you go behind the soft palate and remove the adenoids. This is how, it's another picture. It shows how the adenoid mass is curetted out. And there are various other procedures, we will not go into those details. Then we come to another, the next area, nasopharynx, after the nasopharynx is the oropharynx. The oropharynx, anteriorly it is the soft palate, the palatoglossus muscle, and it is completed by the tongue, upper surface of the tongue, at the junction of the anterior and posterior thirds of the tongue. So these are the ones, called the tonsils, which are behind the palatoglossus muscle, and the structures that you see in the oropharynx are the posterior 2/3, 1/3 of the tongue, the vallicula, that is the space between the epiglottis and the tongue, and the tonsils that are present in the lateral aspect of the pharynx, just behind the palatoglossus muscle, and the anteriorly you have the posterior 1/3 of the tongue. So these are the structures that are present in the oropharynx. The boundaries of the oropharynx, as you have seen, the lateral walls, the palatoglossus muscle, and the tongue, the circumvallate papillae, the base of the tongue, and posteriorly, of course, the posterior pharyngeal wall. Laterally, the same constrictor muscles which are covering that, and inferiorly, you have an imaginary line drawn at the level of the epiglottis, which separates it from the laryngopharynx. So that is about the oropharynx. These are the structures that are present. The palatoglossus muscle, this is important, and behind that is the tonsil, palatine tonsil. And you have another fold which is called the palatopharyngeus muscle, and inferiorly or anteriorly the circumvallate papillae and the base of tongue. And behind you will see the epiglottis and the vallicula. So that is in brief about the structure of the oropharynx. And these lymphatic drainage is into the jugulo-digastric lymph nodes and retropharyngeal lymph nodes. And the function of the oropharynx is, it is a common passage for the air as well as the food. It helps in the pharyngeal phase of deglutition, forms part of the vocal tract, helps in speech, resonating chamber, helps in appreciation of the taste sensation, and they provide local immunity defense against harmful intruders, the reticuloendothelial system, rich of these various lymphatic collections. Then we go into the hypopharynx. We will not go into the details, but laryngopharynx divided into pyriform fossa, laterally, postcricoid region, and posterior pharyngeal wall. This is how, this is the picture when you take out the posterior part of the pharynx. So this is, we are looking from behind into the nasal cavity, and this is the oral cavity, and this is the larynx. Okay. So we will not go into the details of the laryngopharynx. Then we come to the anatomy of the tonsil. We have dealt with the anatomy of the adenoids and the anatomy of the tonsils, because they form the inner ring of the walled hairs. What are they? The adenoids, the tubal tonsils, the palatine tonsils, and the lingual tonsils. So the anatomy of these tonsils, these are paired lymphoid collections which are between the palatoglossus muscle and the palatopharyngeus muscle, and they are variable in size. This is how you take a tongue depressor and then say this is the tonsillar tissue, the palatine tonsil. Now if you go into the surfaces, the medial surface of the tonsil, there is one big cleft that is called intratonsillar cleft, and you have these small imaginations, which are called the crypts, about 10 to 15 in number, and the mucous membrane that is lining is the squamous epithelium, stratified squamous epithelium, non-keratinized. And largest crypt is called crypta magna. It's called crypta magna. So these are the crypts that are there, and it is lined by stratified squamous epithelium, non-keratinized. That is the medial wall surface of the tonsil. The lateral surface of the tonsil, is, we'll come to the lateral surface later. Anterior surface is just behind the the palatoglossus muscle, and the upper pole extends into the soft palate by semilunar fold of mucous membrane into the soft palate. The lower pole is attached to the tongue. Maybe let me see, there is another diagram here. Okay, this is how it is. This is the upper pole attached to the soft palate, the lower pole attached to the base of the tongue. To the base of the tongue, that is the palatoglossus muscle, and that is the palatopharyngeus muscle. So this is the medial surface of the tonsil, which is projecting into the oropharynx. Then we go to the lateral, the upper pole we have seen, lower pole we have seen how it is attached to the tongue, the base of the tongue. Then you come to the bed of the tonsil. Now if you come to the bed of the tonsil, this is how it is. The bed of the tonsil, this is the one. Now the tonsil is covered by the mucous membrane, a pseudocapsule, and then you have from within outwards the pharyngobasilar fascia. That's the one, the green one that you see. This, as I told you, the tonsil is in a capsule, pseudocapsule, where there is a fibrous, there is a connective tissue, loose connective tissue. This is where the peritonsillar abscess usually is formed, and then the blue one, the peritonsillar abscess. Lateral to that you have the pharyngobasilar fascia, and lateral to that you have the constrictor muscle, and the constrictor muscle on the outside you have the buccopharyngeal fascia, and lateral to that, as I told you, there is a parapharyngeal space. So this is how the bed of the tonsil. It's important to know this bed of the tonsil because this is how the infection spreads from the tonsil region into the peritonsillar area where there is a loose connective tissue, forms the peritonsillitis and peritonsillar abscess. Then it can go laterally, pharyngobasilar fascia, the lymphatics, and through the constrictor muscle into the parapharyngeal space. So parapharyngeal abscess is the other complication of acute tonsillitis. And of course, as I told you, it is also in connection with the posteriorly with the retropharyngeal space. So this is the bed of the tonsil. This is important for you. And the blood supply, of course, is the major blood supply is from the facial artery, branch, tonsillar branch of the facial artery. That's the major one. And you have small contributions from the ascending pharyngeal artery and descending palatine artery, which is a branch of the maxillary artery. And there is a branch from the external carotid, the lingual artery. Lingual artery comes into the oral cavity, and from the lateral aspect of the tongue, it supplies the tonsils inside. So this is the major blood supply is from the facial artery branch, tonsillar branch of the facial artery. That is about the blood supply, and the venous drainage is the paratonsillar vein, which is usually present in the bed of the tonsil, and that is the one which gets injured during tonsillectomy and keeps on repeatedly bleeding, and from there it joins the common facial vein, or sometimes into the pharyngeal plexus, venous plexus, the pterygoid plexus veins. Then the lymphatics they drain into the deep cervical lymph nodes. That's why examination of the tonsillitis or chronic acute is not complete unless you examine the gigulodigastric node. The nerve supply, of course, the trigeminal, the sensory, and the glossopharyngeal nerve, and the via the the plexus, the pterygopalatine ganglion. So that is how the nerve supply to these tonsils. And since the glossopharyngeal nerve is the one supplied, and whenever there is a pain, there is a glossopharyngeal branch which is also supplying the tympanic cavity or the medullary cavity, tympanic plexus in the medullary cavity, and so the pain is referred when there is a infection in the tonsillar region. It is referred to the ear. This is called referred pain. Then we go to the various kinds of infections that can occur in the tonsils, and these are usually classified as acute and chronic tonsillitis. The acute tonsillitis, you have all the various symptoms, the pain, difficulty in swallowing, the redness, and these are usually classified into 4 categories. Now, they are either acute catarrhal, or which is superficial tonsillitis, and that is what acute catarrhal, just the superficial infection of the tonsillitis. And you have another variety which is called acute follicular tonsillitis, where the follicles are seen, where the crypts, from the crypts, the pus comes out and they are seen in the follicular, that is the follicular tonsillitis. And you have the parenchymatous tonsillitis, where the entire tonsil tissue is enlarged, the parenchymatous tonsillitis. And membranous, where the pus purulent discharge that is coming out forms a membrane on the tonsil, which gives rise to membranous. So these are the 4 varieties of acute tonsillitis that are being described: the acute parenchymatous, acute membranous, acute catarrhal, and acute follicular tonsillitis. And these are infections, either the bacterial infections, and usually the organisms commonly associated with them are beta hemolytic streptococci, Haemophilus influenza, and streptococcus. And then you have the various viruses, the adenovirus, Epstein-Barr virus, and herpes virus, which also can give rise to the infections, acute infections of the tonsils. And symptoms you can easily guess: difficult sore throat, difficulty in swallowing, the fever, earache, headache, and generalized fatigue of the body. Then the signs are the ones which you elicit when you examine the patient. You may have bad breath, there is hyperemia of the pillars, soft palate, and the uvula, the red swollen tonsils as you have seen, and sometimes membranous, the enlarged and tender jugulodigastric lymph nodes. This is the criteria for you to make a diagnosis of tonsillitis acute. Then treatment is usually analgesics, supportive therapy, antimicrobial treatment. And the important complications if you don't treat acute conditions, acute tonsillitis, is the commonest complication is the chronic tonsillitis. It becomes chronic. So the chronic ones are mostly irritating, they keep on repeating, and difficult to manage. The acute infections usually they are amenable to the anti-inflammatory analgesics, antibiotics, and the local treatment, the gargles. Whereas the chronic tonsils, they don't respond to medical treatment. They almost always require a surgical procedure. So that is the commonest complication, is the chronic tonsillitis. Apart from that, the local complications, the peritonsillitis, where the infection spreads from the tonsil region into the loose areolar tissue that is present in the lateral aspect of the tonsil, and then the parapharyngeal abscess, how it goes via the constrictor muscle into the lateral wall of the tonsil, bed of the tonsil, into the parapharyngeal space. Then the cervical abscess. Then you have the acute otitis media, rheumatic fever. These are symptomatic general acute glomerulonephritis, subacute bacterial endocarditis. These are the complications of acute tonsillitis. This is one of the complications is abscess. And the differential diagnosis, various differential diagnoses are mentioned: diphtheria and infectious mononucleosis malignancies are to be also looked into. Then the indications for tonsillectomy, there are various indications, but the peritonsillar abscess, after the peritonsillar abscess subsides, you drain, and 6 weeks later you do a tonsillectomy, which is called interval tonsillectomy, which is the indication for a tonsillectomy. Then recurrent infections more than 6 times a year, the possibility of malignancy, and they are hypertrophied wherein they block the passage of the air and produce sleep apnea and the febrile contraction. These are the indications for a tonsil. And chronic tonsillitis usually, there are three varieties that are described. Chronic follicular tonsillitis, just like similar to the acute follicular tonsillitis, where the follicles, you will see the purulent discharge. The chronic parenchymatous, the size of the tonsils increases. A chronic fibroid tissue tonsillitis, wherein repeated infections produce what is known as the fibrous bands, and then the tonsil becomes atrophied or pulled inside. So those are the various factors, various ways in which the chronic tonsillitis presents. And the clinical features are recurrent attacks of acute tonsillitis, chronic irritation, bad taste, and there is conservative treatment. Usually it doesn't really help much, but still you can try initially by trying to take out whatever, if there is any precipitating factor which is producing the tonsillitis. And the treatment is almost always the tonsillectomy, and the procedure for a tonsillectomy, the position and the various other things are to be dealt with in a different time. This is how basically you should try to understand the anatomy of the anatomy of the pharynx, how the conical tube extending from the basis sphenoid to the cricopharyngeal sphincter, how it is open anteriorly but posteriorly and laterally. It is covering the nasopharynx, oropharynx and laryngopharynx. How the laryngopharynx is that is how the nasopharynx, the oropharynx, how it is divided into laryngopharynx. Nasopharynx, the boundaries, lateral wall, the eustachian tube, the fossa of Rosenmuller, and the tissues, the lymphoid collection, which is called the tubal tonsil, and the adenoids, and how the adenoids cause the obstruction of the nasal cavity, and various clinical signs and symptoms, how you manage the adenoids. And then you come to the oral cavity, the oropharynx, how it is divided, separated from the oropharynx with the oral cavity, and posteriorly the posterior pharyngeal wall up to the level of the epiglottis, and then the laryngopharynx, how the various infections of the tonsils produce acute and chronic, and how the acute conditions are managed by the medical management, whereas the chronic ones are almost surgical procedures. And if you don't treat them, the complications that can occur as a result of the infection of the tonsils. So this is in brief about the anatomy of the pharynx, as well as the various disorders of or infections of the oropharynx and the nasopharynx in detail. Laryngopharynx we will deal with later. Thank you.